Okay. Yeah.
Um, so my case report was an abnormal bone lesion of the scapula in a collegiate basketball player, 19-year-old male, Division One, presented to the athletic training clinic with pain in the posterior region of the right shoulder. The athlete was performing a layup when his arm was forced into overhead hyperflexion by a defender. He described hearing a crunch and feeling immediate pain in posterior shoulder. He was able to finish practice. He had a history of left shoulder sublux, which was surgically repaired. Um, Before injury, he experienced symptoms of minor impingement and possible subacromial bursitis of the right shoulder with resistance training. Physical examination, point tenderness over the right posterior distal acromion, right AC joint, and right posterior superior humeral head. The right shoulder appeared inferiorly depressed compared with the left shoulder. Experienced pain with all ranges of motion away from neutral shoulder position, as well as decreased range of motion. After a radiographic eval, the differential included simple bone cyst, aneurysmal bone cyst, chondroblastoma, chondromyoid, fibroma, osteoblastoma, fibrous dysplasia, or eosinophilic granuloma. So the intervention, they put him in a sling for a week, instructed to rest, treat the shoulder with an ice pack and compression for 20 minutes every other hour. Swelling increased the next morning. 8-week rotator cuff strengthening rehab protocol was initiated on the second day after injury. After 2 weeks, shortwave diathermy was used for 20 minutes, and that was added to promote bone and soft tissue healing. So the outcome is kind of also another intervention. So after 9 days of cryo, shortwave diathermy, and rehab, the physician released the patient to gradually return to non-contact basketball drills. After 16 days, full participation in team conditioning, including skill development and aerobic conditioning. 19 days, full contact drills. He still had point tenderness, so they decided to go in and do an open surgical biopsy and arthroscopic evaluation. So the diagnosis ended up being just the simple cyst that was mentioned earlier.
Yeah.
After that, they put him in a sling for 2 weeks. Week 3, the patient performed pain-free range of motion and strengthening exercises. Within 6 weeks, he was able to perform all ranges of motion without pain and allowed to return to resistance training activities. At 9 weeks, he was allowed to return to non-contact drills. 10 weeks allowed to return to limited contact practice. And then 16 weeks, he was reevaluated, healing was complete, and he was released. So I think the proper steps were taken after the injury, before surgery, and after surgery. Interesting to see a cyst cause that much pain and a loss of range of motion. I think the exercises given were good decisions and seemed to be good for the healing process of this athlete. But my question was like, I wonder why the surgery was deemed necessary just off point tenderness. Like it wasn't, he was released, he wasn't affected, he was just point tender. So I'm wondering like what made it necessary to go in and take it out if it was just point tender. Like I have something on my shoulder that's point tender, but they don't go in and take it out because it doesn't affect me. So I just,
Yeah. Like for them to do that biopsy just based off of that, I mean, I wonder if there's other imaging or something that they could have tested for that.
yeah, but it wasn't, it, that's all it said. And I was just like, I mean, the treatment and stuff after the injury I would use again, but I just wonder if surgery was necessary.
Yeah. Yeah. I'm trying to think. I think of all the ones I've listened to, that's the first I've heard where they use the shortwave diathermy, actually.
hmm
Like how long ago that was?
So, like
If not, it's
how old the article was, or how, like what?
yeah.
Do you mean?
Like the article?
I didn't look.
No.
It was in one of the recent journals. So
Oh yeah. Huh.
it was like 2018 or 2019.
Uh,
But
yeah, I just wonder where that is because, like I said, I know we went over it briefly in class, but like I haven't seen it used anywhere yet.
well, and you're also probably not going to see it very many places just because people don't really use it.
Yeah, yeah, exactly. It's like, well,
Yep.
sounds good. All right, so jumping into mine.
All right.
Mine is uh, bilateral simultaneous ACL injury, and it was. Let's see. I've always got this split in like 3 different screens. But basically, it was a 23-year-old female was out skiing, and she had a fall. Uh, they don't describe kind of the substance of the fall, what happened, or how she fell. But that's how I emergency personnel came and got her. She reported hearing a pop in both knees, and she was unable to bear weight on her left and her right. It wasn't that bothersome initially, but it did irritate her rotating. So they okay. My write-up's gotta be easier to read than trying to read the highlighted section. Sorry. Um, yeah, so of course, first went to a emergency medical physician, so I'm guessing the ER to
Mhm.
get taken care of. Um, and there, I said, unable to bear weight on the left leg. Um, so she was referred to the author's facility, which this was written by. Doesn't say where exactly, but it says it's Women's Hospital Boston and Boston University School of Medicine. So that's probably it. But she was referred there. They evaluated her and like their special tests and stuff bilaterally had significant effusion, positive Lockman, and increased valgus laxity, or laxity from valgus stress testing, and reduced range of motion in both of her knees. The right knee also was point tender on the lateral joint line. So they did imaging, and an X-ray showed uh, left fibular styloid process, a bull fracture, and then the MRI also showed a non-displaced fibular head fracture on that same side. The MRI also showed bilateral ACL ruptures. They didn't give it a grade. It wasn't noted. Partial thickness radial tear of the posterior horn of the lateral meniscus, long things, MCL sprains, subchondral fractures. It's like pretty much, and all this, it was all written as if it was the same bilaterally. So it's kind of a little fuzzy. It was meant more focus on their treatment, on their interventions. And the intervention basically was they decided to do a staged process for reconstruction. So where they did the left ACL 1 week post injury, they did the reconstruction then, and they did the right ACL 8 weeks post injury using a tibialis anterior allograft, which I hadn't heard of that one previous to this. I had heard of patellar tendon and the hamstring.
Wait, which one did they use again?
It's tibialis anterior allograft.
I've heard of it, but I don't think it's used a lot.
Yeah, and in their discussion, it gets into that some. But yeah, so they didn't really discuss any further rehab, like what their rehab plan was or how they went about that, just the surgery.
Mm-hmm.
Um, previously the emergency physician gave her ice, anti-inflammatories, and crutches. So it's like standard get out of our ER type stuff. Um, and then 5 months after the right knee was reconstructed, so 7 months total, she was suffering still from a contracture of the knee flexion contracture and pain and tenderness of the tibial tunnel. So they went back in, put her back under for manual manipulation. Yeah, right knee manipulation and debridement of a cyclops lesion that had impaired the recovery during that period. Pretty much all of this came out to, see, 7 months after the initial injury, with her right knee, or sorry, with her left knee, she was able to return to elliptical and bicycle. So makes it seem like she was doing that unilateral, like just with her left knee. Due to the complications in her right knee, it delayed her recovery, and she was able to, yeah, after that mentions the reconstruction or the follow-up 5 months after the debridement. She recovered well, but it was a total of 15 months after the injury that she was finally able to return to skiing. And the final follow-up was 2.5 years after the reconstruction. She's doing fine, back to skiing, not having other complications or anything like that. So, but I said they don't really discuss more beyond the surgical intervention. And in their discussion, they actually sent out a survey to other orthopedic surgeons or directors. And they had, let's see, 43 of 107 surgeons responded. And it was pretty much asking them in their surgical interventions how they would treat this and how many had seen it. And it was, let me see, the charts are just easier than trying to find in my, of the 43, like average of 18 years in practice, 22 of them had never seen this type of injury, a simultaneous bilateral ACL injury, rupture. 8 had cared for 1, 6 had cared for 2, and 7 had cared for 3 or more. So very rare. Not many of them had seen it. And then they were asked how they would treat it as far as doing a staged surgical reconstruction, as this patient was, or a simultaneous, so doing them both at the same time. And of that, they said that all have done, the studies have been show that overall recovery time is shortened doing simultaneous reconstruction. But even at that, of all the surgeons, they asked them all how they would care for it. And it was, see, let me find the exact sentence. Contrary to what literature would suggest, about half of the surgeons with experience in treating bilateral ACL injuries believe that simultaneous reconstruction increases rehabilitation time. But that was kind of interesting to me, that it's like they're saying that, you know, the literature and everything suggests that that should be quicker. But my question on this is kind of, I wasn't sure if, you know, if you had someone who had a bilateral reconstruction simultaneous, how would they ambulate? You know, it's like, would they have to be, you know, because if their knee has to remain straight or slightly flexed for an extended period. It's like, are they going to be in a wheelchair with both legs straight out? And then is that why these surgeons are making that determination to do it staged? So
Yeah.
you have it, do the worst one first, and you could remain on crutches or something like that. So, but
Yeah. I
yeah,
feel like if I were the athlete, I would want them done at the same time, though.
yeah,
That could have had a
and,
factor.
yeah, and they did note that. This is the funny thing. They never said exactly which direction. They said gender of the patient didn't really sway their decision one way or the other, but
Mhm.
age did. And that's the other thing where they mention in here 2 or 3 times that the surgeons mentioned age would be a factor in how they decided, but they didn't note which way which way it
Yeah.
would sway it. So, but yeah, I mean, I'm wondering if it was possible for this person to get it simultaneous. It probably would have been quicker than 15 months of
Yeah.
total recovery time. Yeah, that's
Well, maybe.
maybe. Of course, you never know unless you actually see what happens. So
Yeah, and especially
yeah,
since you don't see that happen very often.
yeah. Like I said, of 43, it's like only why I say 22 had seen it. It's like incredibly rare. And of those, where was it? It was like the average years of experience, years in practice of the ones that had seen it was like 19 years. So that's a lot of hours in clinic to see that few. So
Yeah, for sure.
and I believe that's it.
Mhm.